Dr. Balkis. Oke. Dr. Ahmad Fuadi. Belum ya? Dr. Inge Damanti. Ya. Dr. Julita Hendartini, Dr. Teguh Dartanto. Oke, masih beberapa ya. Awas Bu, jatuh Bu. 1, 2, 3, 4, 5, 6, 7, 8, 8, 4 lagi. Okay, I will collect the names once again. Dr. Sanderson Oni, Professor Hasbullah, Dr. Irmansyah, Professor Rina Agustina, not here yet. Not here yet, okay? Professor Asnawi Abdullah is on the way. Professor Byron J. Good, Dr. Wahyu Puji. Dr. Balkis, is it here already? Not yet. Dr. Ahmad Fuadi. Oke. Dr. Inga Damanti, Dr. Julita, Dr. Teguh, oke. Okay, how do we supposed to start the practice? Is it already? Okay, enough. Okay, thank you, ladies and gentlemen. So please memorize the exact spot that you will stand on the main stage later. Thank you. Thank you, Professor Byron.
Testing 1, 2, 3, testing. Segini oke? Ya. Oke, terima kasih Pak. Ya. Ini tidak ada pidana seperti itu. Jadi hal-hal
Bapak, Ibu, dan hadirin yang kami hormati, mohon dapat menempatkan diri di kursi yang telah disediakan karena acara akan segera dimulai. Sekali lagi kami mengundang Bapak dan Ibu dan hadirin sekalian yang telah hadir di dalam auditorium Leimena untuk dapat menempatkan diri di kursi yang telah tersedia karena acara akan segera dimulai. Terima kasih. Ladies and gentlemen, distinguished guests, welcome to the Lancet Regional Health Western Pacific Commission launch, Reimagining Healthcare in Indonesia for 2045. Our program will begin shortly. May we kindly request all attendees to proceed to their seats and set all mobile devices to silent mode. Thank you. Ladies and gentlemen, Minister of Health of the Republic of Indonesia is entering the room. Distinguished guests, to begin our formal proceedings and honor our country, ladies and gentlemen, please rise as we sing our national anthem, Indonesia Raya. Our national anthem, Indonesia Raya. Thank you. Distinguished guests, please be seated. Ladies and gentlemen, to set the tone for today's monumental event, let us pause and bow our heads in prayer. Prayer commences. This concludes our prayer. Distinguished guests, today marks a major milestone in global health, the launch of the Lancet Regional Health Western Pacific Commission. Indonesia is honored to lead the prestigious, independent multi-layers initiative to design a blueprint that reimagines our health system for 2045, ensuring no one is left behind. Realizing this future requires all of us, here and online. We invite all stakeholders to collaborate with the commissioners through workshops, data sharing, and joint publications. Collectively, we hold the power to translate these recommendations into tangible actions to safeguard the health of our nation. Please join me in welcoming Dr. Jie Chai, the editor-in-chief of the Lancet Regional Health Western Pacific, one of the world's leading medical journals and the host journal of this commission. to deliver her introductory address and outline the significance of this Lancet Journal Commission. Dr. Chiachai, the floor is yours.
Distinguished ministers, commissioners, colleagues, and friends. Thank you for joining the kickoff meeting of the Lancet Regional Health Western Pacific Commission on Reimagining in Indonesia, Reimagine Healthcare in Indonesia for 2045. It's a great honor to be here today with you. There are so many people I want to thank to make this commission kickoff meeting possible. Just like what I said at the earlier of today, this is just an easier start, and we will work together to make the commission possible. There will be a lot of debate, there's a lot of arguments, but after all, we have the common goal to make the mission possible. Let me start with a brief introduction about the Lancet Family Journals and our engagement with researchers and clinicians from Indonesia. The Lancet is a global medical journal founded in 1823. Yeah, I just realized we are much younger than Jakarta. Yeah. It has expanded into the Lancet Family Journal with 28 specialty titles, including 6 regional health titles, 9 with WHO-defined region. Global health is a strong focus of our Lancet journals, and we view global health through the lens not only on health itself, but also health equity and social justice. Our relationship with Indonesia goes back many years. Across the Lancet family journals, we have had the privilege of publishing some very important work, document Indonesia's health reforms and innovations. For example, the landmark summit trial, which showed positive impact of maternal multiple micronutrients supplementations on fetal news and infant mortality. The trial and follow-up analysis provide critical evidence for maternal and children health, both in Indonesia and internationally. There's another example, Professor Rina Agustina, who is here, and also Professor Hasbullah, who are co-chair of today's commission. Together with colleagues from the Indonesia Health System Group, have provided comprehensive analysis of the challenges and also the opportunities in Indonesia's progress toward universal health coverage. As Richard Horton, editor-in-chief of The Lancet, wrote 10 years ago, Indonesia's value, its predicaments, and its attempted solutions have enormous global bearing. The statements remain just as relevant today. Driven by the economic growth and health reforms, population health in Indonesia have improved greatly. And that's also, and thanks for the contribution for many of you here today. But the health gains are not even. Besides, the health system is under constant pressures of raising demands from non-communicable disease, workforce shortage and uneven distribution, and growing risk from health emergency and natural disasters, to just name a few. Addressing these structural pressures and inequity requires a more resilient, people-central, and sustainable health system. This brings us to the purpose of the Commission today. How we can adapt the health system to deliver equitable, high-quality care for all Indonesians in a rapidly changed health landscape. Lancet Commission assigns needs international and multidisciplinary collaborations that arm for transformation change, particularly in policy and political action. Building on Indonesia's own evidence, expertise, and leadership, the Commission on Reimagining Healthcare in Indonesia for 2045 will take a forward-looking approach, engage multiple stakeholders to identify the key health challenges, both immediately and over the next two decades. And most importantly, to generate evidence-based recommendations that could guide policy towards a healthier and more equitable Indonesia by 2045. I very much look forward to the discussion later today. Thank you so much.
Thank you, Dr. Jay Chai, for anchoring our local efforts onto the global health stage. Dr. Jay Chai has reminded us of the prestige of the Lancet Group as an independent, global, agenda-setting voice. A round of applause for Dr. Jay Chai once again. Ladies and gentlemen, to present the structural policy frameworks of this report, it is my privilege to invite the founding co-chair of the Commission. Please welcome Dr. Sanderson Oni, Chair of Wellspring Center Indonesia and Research Fellow at Harvard Medical School, to the podium.
To the Honorable Minister of Health, distinguished guests, fellow researchers, partners, and friends, thank you for being here. Minister, your presence today is more than a courtesy. It signals a minister and a ministry that supports research and is committed to high-quality evidence for action, and we as a country are privileged for it. We thank you for the opportunity to work together with BKPK, the ministry's independent policy agency, to help draw a blueprint for our country's future. Now, Indonesia is famous for many things, but what I've noticed as an academic is that in the health space, we are famous for doing so much, yet publishing only a fraction of that. We innovate in our puskesmas, in our primary healthcare, and across the healthcare system, but much of that work, sadly, is never written, and because it is never written, it does not enter into the global literature, and it does not inform the global guidelines that are then back applied into this country. For too long, Indonesia has done the work without being counted or represented in the global evidence base and literature. We hope that today that changes. This is the first Lancet Journal Commission to be led and co-chaired by Indonesians, and one of the only few country commissions to exist in the history of the Lancet journals. It means the story of Indonesia's health system will be told along the future that we hope for. Now, the commission itself is actually quite simple. It is a team of people writing a blueprint that's 25,000 words long. That's the article. It will be published hopefully several years from now by its commissioners and its co-authors. But for us, the commission is so much more than that. That end point, the article, that's the end of the road, but it's the journey that we hope to take together is what counts. You might be thinking, what are we doing at 9 a.m. on a Monday morning here today? It's an invitation, because it's not that one article that only that matters, but it's working together to make sure every voice is heard, to be able to increase the publication ecosystem of the entire country and the health stakeholders, that every person in this room and for those watching online, that we all benefit from not only the end article, but the process and the journey that we take together. Now let me have the privilege to share with you what is the core vision of this commission. Now we know, and we've heard before, that we envision in Indonesia a masa golden Indonesia with the largest productive workforce, a time of potential prosperity. However, history gives its warnings. Throughout history, one of the main reasons that civilizations fall is when we forget to take care of the poor the remote, and the marginalized. Our vision is that by 2045, building on the incredible work already done by the ministry, Indonesia's 100th anniversary, that the poorest, the most remote, the most marginalized populations can access quality healthcare with dignity and cultural sensitivity. Helping somebody become healthier in our vision isn't giving them medication and telling them to go away. It is not simply letting them know, if you want something, you come back. No, we sit with them, we walk with them, we eat together, and we break bread with them. That is a vision of 2045 that we have. Now, I realize this sounds like a little bit of a dream. I realize that to many of you, this might sound a little bit far-fetched. But as somebody who's worked in a health system in over 70 countries and advised global policy at the highest level, I say we need to start with a blueprint, one that is evidence-based, one that is based on data, and one that has concrete steps to achieve that vision. So throughout this commission, we're going to hear later from Professor Hasbullah as well, what are the different chapters and how do you get involved? But we are going to be facing difficult truths. And in front of you, there's a piece of paper that outlines what these chapters are. We will hope to build and reimagine in primary and secondary healthcare, as we know that a lot of the puskesmas, even in our wealthiest cities, are overburdened. We're hoping to design an emergency response for conflict and for climate disasters. We will ask plainly who is being left behind and what it takes to reach them. We will even confront the difficult issue of misconduct, discrimination, and bullying in our medical education and specialist training. We will also model the real resource this vision needs, so it not only lives as a dream, but as a plan that we can work together. To do this, we're bringing together over 25 of our country's finest researchers, many of which you will see soon. We have absolutely incredible people, and I hope you get in touch with them. I listen to the work that Bu Balkis does, and I'm constantly in awe. I see the leadership that Prof. Asnawi has in the country. I see these incredible people, and together they will be the commissioners and leading this commission that we have. There's a clear focus on building national capacity, gender equity, and strong representation, especially from Eastern Indonesia, dari Indonesia Timur. And so I invite you along for this journey. To the government and to the wider health ecosystem, let us work together. The literature, especially the global literature, may not understand the challenges you face in the field. Di rumah sakit, di poltekkes, they may not understand your realities. Let us bring it to the surface so that we're represented. Let us work together to analyze and publish data together, to have workshops to understand what's actually happening on the ground. We want to sit with you and hear your stories. This is not one article and a closing ceremony. Again, our ambition is to lift Indonesia's health publication to the new level. To people who have lived experience with illness, who are marginalized, who have been neglected, especially many of the people watching from across Indonesia, come, let your voices be heard. To our development partners, we're eager to continue partnering with you, and we thank you for the incredible work that you've done in this country. We hope that you'll support us and we can answer some of the key unanswered questions that we have left in this country. For example, who is pushed into catastrophic spending simply because they fell ill? And to my fellow commissioners, and to the researchers across Indonesia, let us be clear about the greatest threat to this commission and to research in this country. It is not a lack of funding. It is not a lack of talent, that's for sure. It is the moment we place our own egos above the good of the country. We are servants for the people of Indonesia. So let me close with this. Professor Paul Farmer taught us that we cannot build a health system we have not first dared to imagine. A failure of the imagination, as he would call it. And the failure of imagination comes before the failure of the system. So let us imagine together, not a fantasy, but a future built on evidence, on strategy, on data, and on collaboration. Let us imagine together in Indonesia that at its 100th year, what is it known for? It can look to the end of the longest road, to the poorest home and the most distant island and say, you too are seen. You too are counted, and you too are cared for with dignity. Thank you.
We express our profound thanks to Dr. Sanderson Oni for that illuminating summary. Please give applause to Dr. Sanderson Oni once again. May we respectfully request Dr. Sanderson to kindly remain on the stage. Ladies and gentlemen, we now proceed to the official Lancet Commission launch ceremony. As a symbol of our shared commitment and dedication, to begin this moment, we kindly invite the commissioners to the stage. As co-chairs Lancet Regional Health Western Pacific, Dr. Sanderson Oni, Harvard Medical School and Wellspring Center, Indonesia. Professor Dr. Hasbullah Tabrani, University of Indonesia. Dr. Irmansyah, National Research and Innovation Agency. Professor Dr. Rina Agustina, University of Indonesia. As Commissioner Advisor, Lancet Regional Health Western Pacific. Professor Asnawi Abdullah, Health Policy Agency of Ministry of Health. Professor Byron J. Good, Harvard Medical School. As Working Group Lead, History of Indonesian Healthcare and Achievement thus far, Dr. Wahyu Puji Nugraheni, National Research and Innovation Agency. For the chapter of Decentralization and Primary Healthcare, Dr. Balkis Hasanuddin, University as Working Group Lead. Dr. Ahmad Fuadi, University of Indonesia. For the chapter of Secondary and Tertiary Healthcare, Dr. Inge Damanti, Airlangga University as Working Group Lead. Dr. Julita Hendrartini, Gajah Mada University. For the chapter of Financing on Equitable UHC, Dr. Teguh Dartanto, University of Indonesia. These are the core commissioners, with more to be recruited on an ongoing basis. Now, with all our distinguished commissioners on stage, we would like to invite the Minister of Health of the Republic of Indonesia, His Excellency Budi Gunadi Sadikin, accompanied by Vice Minister of Health, and Dr. Ye Chai, to kindly step up to the main stage to present the commemorative plaques to the co-chairs and commissioners. take the picture in the count of 1, 2, 3. And one more time, with your best smile. 1, 2, 3. Okay? May we respectfully the request to Honorable Minister of Health to kindly remain on the stage. Thank you, Dr. Jie Chai, co-chairs, and all commissioners. You may now return to your seats. His Excellency Budi Gunadi Sadikin to deliver his remarks. The stage is yours.
Ibu Cecia, Pak Oni, Pak Brian, anggota komisioner, hadirin sekalian, Assalamualaikum warahmatullahi wabarakatuh. First, I would like to congratulate all of you. I'm very proud because this is the first time that I heard the Lancet commissions is head by an Indonesian scientist. So hopefully we will soon also, during my time, we can increase from regional Lancet to international Lancet. Commission paper also will be led by Indonesian researcher. I also would like to apologize that I'm late, a little bit late coming to this meeting because I have to do some call related with the parliament, but hopefully it will not hold you so long. The first message that I would like to share with you is healthcare is very important to reach Indonesian ambitions in 2045. They call it the golden era of Indonesia, Indonesia Emas. It doesn't mean that Indonesia will buying a lot of gold because many central banks now are accumulating gold for their reserve, but it is actually Indonesia would like to be a high-income country by 2045. And for somebody with economic background like me and somebody from University of Indonesia sitting there as one of your member, high-income country has a very distinct target. Our GDP, GNI per capita should be above 14,000 US dollar per annum. Indonesia is around 5,000. So we almost have to triple our GNI per capita. And during the history of many developed nations, they able to reach or to become successfully a high-income country, most of them during the peak of their demographic bonus. Why? Mathematically, it's very simple. GDP per capita means if you have the highest GDP with the lowest number of population, then there is a good chance you will reach the high-income country. The demographic bonus just means that, because during peak of demographic bonus, the number of productive people that can generate value, GDP, is the most. I think around more than 60% of Indonesian people at the peak of our demographic bonus are in a productive range. So that is the time where most likely Indonesia can break the barrier to become high-income country. And that will happen during 2030-2035. What happens if we fail to achieve high-income country status at the peak of our demographic bonus in the next 5 to 10 years? Then, the old people like me, like Dr. Benny, because in Indonesia, if you are above 60, like me, Pak Hasbullah, Dr. Benny, your status become elderly. And elderly means that you are not productive, because you are not be able to generate money as much as Dr. Oni, So then, after demographic bonus, the population of elderly become more dominating. The population is aging. That will make it more difficult for every nation and every country to break the barrier of high income country level if they haven't done so. and they will live forever in middle income country. The economists call it a middle income trap. Middle income trap. Many countries in the world is already there. Many countries in Eastern Europe, many countries in Middle East, Latin America, they are trapped forever of their history as a nation that will not become high-income country. Because if they want to become a high-income country, the productivity level should be extremely high. People like me has to be still working and earn money as much as Dr. Oni until I reach 70, which is very difficult, very difficult. So that's why, ladies and gentlemen, we have a short window of, by the way, Chichen is from China. China is already aging, the population. Luckily, China already reached 14,000, barely. So when they're going down, they're already there. And you can feel it. You come to a country, you can feel. This is high income, this is a middle income. You can see from the building, the airport, you have that feeling. So China can make it. Thailand is already aging. They haven't touched a 14,000 barrier. So Thailand can be trapped in the middle income status forever if they don't do something that can increase their productivity significantly. Indonesia is still young, and we have 5 to 10 years ago. If we miss that opportunity, during 2030, 2035, we are fighting with each other, we are doing a demonstration instead of doing something productive, then we make the greatest sin to our children and the children of our children, that they will never be able to live in a high-income countries. So remember that. Remember that. If we fail in the next 5 to 10 years to bring Indonesian GNI per capita above 14,000 US, then that is the biggest sin of us to our future generations. So ladies and gentlemen, now the second message that I would like to share with you. So how do we do that? Because you are talking about GNI per capita income. Yes, you need infrastructure. Yes, you need natural resources. But the measure of high-income country is not natural resources. It's not infrastructure. It's not number of airplanes. It's not trade. It's not stock price. It's not currency. The measure of high-income country is GNI per capita. How much each people earn every year. Each people. So we are talking about people. And my argument is very simple. I'm a banker. But my argument to my colleague Minister of Finance, Coordinating Minister of Economic Affairs, and my friend from Faculty of Economy in the Republic Indonesia sitting there, University of Indonesia, is GNI per capita. So not GNI, but per capita. Capita is people. So my argument is simple. If you don't have people that is smart and healthy, you will never be able to make them having an average income annually 14,000 US. The difference between people that can earn above 14,000 and below 14,000, they are smarter and they are healthier. They are smarter and they are healthier. If your people, your population, 280 million Indonesians are not healthy and are not smart, impossible you can reach 14,000 per capita per annum. How much natural resources you have, how many infrastructure, builders, road, seaport, airport you build, how much volume of trade you created, you will never achieve if your people are not healthy and smart. And definitely I will put health, first. Not because I'm the Minister of Health. I always argue to Minister of Education, hey, your job is simple. Your job, you only treat people when they reach 7 until they reach 35, 40 when you get a PhD and stop. My job, I started -9. Before the pregnancy is still a pregnancy, before you give birth, you already make sure that they are healthy, because otherwise they get stunted. And they get stunted whatever, how smart your teachers, how beautiful your school, impossible for stunted children, to get smart. So my job is more difficult than you. I started -9 before birth until you die, which is Indonesia now 74. I have 12 years to go, by the way. Dr. Benny have 11 years to go. You are so shorter. Yeah? Yeah? But except you move to Yogyakarta, because Yogyakarta average life is longer than Jakarta, yeah? Unless you move there. So that is something, the second thing that I would like to share with you. We need to create a healthy and smart people. And then how to make a healthy people. That is the first slide that I would like to share with you. You know, our target, 2029, is we have 20 years plan, 2035, 2045. So the Lancet Commission need to understand that, so you align with the directions of the country. Not many people have read this document, but this document is made by me. Document is made by the Central Planning Committee. And then we have a 5 years plan made by them also. There are 4 strategic outcomes that we have to deliver. But just to give you the summary. Number 1, we want to increase the average life expectancy from 72 to 76. So now I'm 62. I want to live not only for another 10 years. I want to live for another 14 years. Pak Hasbullah and Pak Agus there, which is closer to that area, be careful. Yeah, be careful. You have a shorter period. But our job is to increase from 72 to 76. I'm very proud that last year is already 74. So hopefully we can do more than 76. By the way, US is 79. So we are not bad. China, I think, is 76 now. Yeah? And China plan also, they already established the Communist Party plan. They want to increase it from 76 to 78, if I'm not mistaken. Yeah? We want to hit 76. For me personally, I want to hit 80, so I can live another 18 years. Yeah? Betul, Pak Hasbullah, right? Or we go like Singapore, 84, Japan, 84. Yeah? Our ambition, we need, but the target given to us, mandate given to me, 76 in the next 5 years. Second target, the HALE, we call it, the Healthy Adjusted Life Expectancy, 60 to 65. So Dr. Benny, you are 63, I'm 62. We can prove whether in the next 2 or 3 years, we are still live healthy. Or we limp, or we got stroke, we cannot walk, or we got dementia, or whatever it is. We do hope that we don't. But we would like to increase the average healthy life from 60 to 65. The third target, because the other one target is given to BKKBN, the fertility rate. But the third target is the Universal Health Coverage Service Coverage Index, which is in Indonesia, I don't understand why, it's always being perceived wrongly, especially by my friend from BPJS. We have universal health coverage, 99%. When I read, and we rank number 1 in the world, the best in the world. When I read the paper, we rank number 122 in the world. You know, why the difference? Or the definition of Indonesian universal health coverage is the number of people that hold the BPJS card, which that is not the case. You have the BPJS card, you go to hospital, you cannot get served because the hospital is not ready. That doesn't mean universal health coverage. The real universal health coverage is whether you can access healthcare services with a good quality without financial hardships everywhere, every time. If you have a card, doesn't mean that you have access. You have a card in Sumba, you want to have a cesarean operation, there is no OBGYN in Sumba. And the OBGYN is not allowing the GP to do cesarean operation. So you can only die if you have complication in Sumba or Nias, because they cannot do a cesarean operation in there. So that is no access. That doesn't mean you have access. The Surface Coverage Index, the target we want to go to 69 from 63 that we have. The surface coverage. So those are the 3 targets. The message number 3. The message number 1 is what do you call it? The demographic bonus. Message number 2 is make sure that we focus on the people to make it healthy, and this is message number 3, how to do it. And then the strategic outcome, those key target has been translated into strategic outcomes. And the next one, the strategic outcomes, the next slide please, have been also translated into 41 indicators, strategic indicators that we need to achieve by 2029. So these indicators, and they have the numbers, like that one. One of the numbers is average life. The other one is average healthy life. Another one, mother mortality, children mortality, immunization target. So all these 41 indicators is already agreed by the government and by the parliament as the strategic indicators. It is not many people understand this. So this is why I would like to spend some time to share it with you. And to achieve these 41 strategic indicators, we created strategic programs. Next slide. This is the last slide that I would like to share with you. And this strategic program we cluster into 6. The first cluster is about primary healthcare, which is closest to my heart. The second is secondary healthcare. The third is healthcare resiliency. Number 4 is healthcare financing. Number 5 is healthcare human resources. And number 6 is healthcare technology. And there are many programs launched by the government under this program cluster. The objective is to achieve the 41 strategic outcomes, strategic target indicators, strategic indicators, and then to achieve the 6 strategic outcomes. So if you want to do research, please do research according to this framework. And there are many data that are available now. I'll give you one example, because I'm very close to the primary care. It's closest to my heart. Primary care, we have 10,000 puskesmas. I inherited that puskesmas. But in this puskesmas, where 4.8 million babies mostly born there, only 2,200 has an ultrasound by 2022. So we deploy 10,000 ultrasound in 2 years. So you can do a lot of research, because by doing ultrasound, we can reduce child and mother mortality, which is extremely high in Indonesia, because of the complicacy during delivery. In Indonesia, 2 years ago, we launched 3 new antigen of vaccinations: HPV, rotavirus, and also PCV. Cervical cancer everywhere in the world is declining. Indonesia is going like that. Why? Because we haven't launched the HPV vaccination programs until 2022. So we quickly launched in 2022. Now we started with 10 to 11 cohort. We already started with 15, catch up with 15 to 16 years lady. And now last year we started with 21, and next year we will start with the boys. So we would like to be extremely aggressive in HPV vaccination. You can do a lot of research on the immunization side. Now after COVID, you know, the non-communicable diseases is the #1 burden. Number 1 is stroke, 300,000 deaths, heart attack, 250,000 deaths, cancer, 234,000, and kidney, 160,000 deaths. So number 1, number 2, number 4 is a cardiovascular issues, because kidney, most of the kidney problem because of diabetes. So we launched last year the most aggressive landmark program that we have ever done in primary care. The 280 million free healthcare screening every year. And when you see the numbers, hypertension is whatever, very high, blood sugar is very high, cholesterol is very high. The data is there by name, by address. We only successfully screened 70 million first year. Not bad. This year, Ibu Endang target is 136 million. Next year, maybe 180, and then hopefully in 5 years, 280 million, starting from newborn screening until elderly screening will be done, including cancer and also for mental health. So that will be a massive amount of data that you can do. And now we are focusing on how to handle if we have hypertension with a free whatever amlodipine given every day. Yeah? We will very, very soon deploy 10,000 EKG with thrombolysis facility using 10-hectare place at 10,000 Puskesmas. Now it's being pilot project. Why? Because heart attack is killer number one. So hopefully with the AKG, if there is an indication of STEMI, you can identify early and deliver the treatment at the Puskesmas level before you send it to the hospital. That is also one of the most aggressive programs to take care about NCDs. We already get funded to deploy 10,000 X-rays. Yeah, Dr. Benny is leading this initiative because we would like to reduce 160,000 deaths because of tuberculosis. Every 5 minutes I talk, 2 Indonesians die because of tuberculosis, which is ridiculous. So we would like to deploy 10,000 X-rays. The budget is already there. We already start the procurement. So you can do a lot of research. What will happen if the X-ray facilities starting next year will be available at the Puskesmas? And X-ray is not only used for lung. They can use for kidney. They can use for other instruments. We will also start deploying this year and next year 10,000 mini PCR at 10,000 Puskesmas, where you can do microbiological testing at the Puskesmas facility. So your surveillance capability will be increased drastically. Because basically, theoretically, you can test any pathogen, whether it's virus, bacteria, parasite, at 10,000 Puskesmas. Like you have a PCR facility at 10,000 Puskesmas. This will improve our surveillance capability for any infectious disease massively in those Puskesmas. So those are the things that we have done. We do a lot also in the second reform. We deploy 400 cath lab, 400 CT scan, MRI, endoscopy, colonoscopy, whatever it is, mammogram in 514 cities. And I would like to touch also on the health system resilience. When I joined, we only have one vaccine company. Now we have 3 vaccines company. We have, during COVID, we are depend on import, like example, albumin, IVIG, factor 8, factor 9, gamma ras is needed. The price is so expensive because Indonesia don't have the plasma refraction factory, which is ridiculous because Indonesia is number 4 populations in the world. So in terms of natural resources, we are the 4th number of blood supplier, but we don't have IVIG. We don't have albumin factory. So we changed the regulation in 2024. Investor coming in from South Korea, 2026 is ready. By 2027, next year, they will produce 600,000 liters every year. The first plasma-derived products in Indonesia. The second investor, this is only 300 million investment. The second investor from Japan will invest $1 billion to build a 1 million capacity for albumin and IVIG, which is mostly needed by the people in Indonesia in the healthcare system resiliency. In healthcare financing, we changed the DRG, hopefully will be approved very, very soon. We changed also the payment mechanism, not based by a title, but based by competency. So if you are specialist or subspecialist, there is no difference in terms of payment, because otherwise the Indonesians are working to get the title. I don't think if you have the title, you are as good as the title below you. So that's why we will reform. Everything is based on competency. So there will, to avoid also infightings between specialty. If you are a radiologist, you are an interventionist, if you are the cardiologist, as long as you can do primary PCI, you will pay the same. You will be paid the same. So that is also the reform BPJS. And BPJS, we also do reform to combine benefit with private insurance. BPJS cover only like 25% of our national healthcare expenditure. So 40 to 40 billion every year, they cover only 25%. I want to increase it to 80%. Strengthen BPJS, not only by government subsidy, but gradually adjust the price, and to make sure also BPJS combined with private sector, so both systems can carry most of the healthcare expenditure. So the government and the 280 million people will have a negotiating power, to the healthcare provider, the hospitals, the doctors, the pharmaceutical company. Because otherwise, if we miss to do it, then we go to like United States, 79 years average life, average cost per capita, 11,000. Japan 84, average 5,000. Singapore 84, average cost is 3,500. Because why? Because the patients do not have the negotiating power to the healthcare supplier, the hospital, the doctors, and the pharmaceutical company. So why price increase very high? The simple appendectomy cost in the United States is 12,000 US. Japan 5,000 US. Indonesia 300 US. This is the most ridiculous industry I've ever seen in terms of price. I don't understand why the US citizen want to do appendectomy in the US. I will fly to Japan. You buy a $2,000 ticket and go to Japan. China is even cheaper. And I don't think the Japanese doctor quality to do an appendectomy is 1/10 of the scale of the American doctors. So this is the industry that we need more transparency. So your job as a researcher, please do it. Do some comparison. In finance industry, it will never happen. Never happen the US dollar to renminbi exchange price different in New York and in China. The difference only 1%, 2%. Never 300% or 500% like what happened in healthcare industry. This is the most ridiculous industry in terms of cost to deliver the services. So that's why the reform number 4. I would like to close the reform number 6 because you are talking about innovation. In reform number 6, we create a lot of programs to leapfrog in biotechnology and AI. So Indonesia creating a national committee on AI, creating a national committee on biotechnology, because we believe this is something that we can go. We established successfully the National Biogenomic Initiative, where now we are start recruiting 20,000 every year whole genome sequencing. Next year, I will push it to 50,000 every year and then 100,000 every year. Because we managed to reduce the price of whole genome sequencing from 1,000 to 2,000 when the Singaporeans start doing it to below 200 with the help of the company from China, PGI. Now, hopefully, starting next year, we can reduce it below 200 US with the new T20 machines. Whole genome sequence, once, this one. And then we will use this biogenomic facility to do screening also at the Puskesmas level, the free screening programs. Now we don't have the capability to do it. But once we reach a certain economic of scale, then we will push the BRCA1, BRCA2 screening at the Puskesmas level. Instead of only do ultrasound to identify the early indications of breast cancer. Yeah, we will do the BRCA1, BRCA2 at the Puskesmas level. So advancement in healthcare technology is amazing. So this is something that we would like to leapfrog. Before diabetes, you get insulin. Now diabetes, you get GLP-1. And you get a bonus because you look better. Gitu kan? I have a high cholesterol level. Before I take rosuvastatin, now I took a PCSK9 inhibitor because it's faster to reduce my LDL especially. Yeah, because I'm above 60. So the leapfrog in biotechnology is amazing. AI is the most interesting thing. We do a lot of clinical trial for AI machines. Yeah. This AI, in terms of sensitivity and specificity, sometimes can compete with specialists. To my surprise, it's like when you play chess, sometimes the computer is smarter than the grandmaster in chess. So AI is also evolving into that directions. So massively using AI in reading radiology, reading pathology anatomy, reading CT scan, ultrasound, X-rays. We are heavily using AI for our free screening programs. So to help the doctors give the right advice. If your blood check is like this, we send it to the AI before we send it to the doctor, so it can augment the doctor to identify something that he might miss. Something that he might miss. A sample comparison. Because the AI machines have studied 1 million or 2 million patients, where the doctor maybe study 1,000 or 2,000 patients. So that will augment the doctor's capability. The standard is there. Many administrative functions will be AI-based. When you talk to the patient, rather than write it down, we can record this and then use AI to translate and put it into the electronic medical record. So the doctor increase the efficiency. so they don't have to do it. So many simple initiative is done at that side. And this is something that I need you to help do some research. Because while we are busy doing things, we don't record, we don't research, we don't report, because we're busy. Pak Budi, why don't you write a book? I don't have time to write a book. I want to save lives. Ladies and gentlemen, the future is not something that we inherit. The future is something that we need to build. So have a healthy life and also a long life. Thank you.
We express our utmost gratitude to the Minister of Health for his inspiring vision. Before the Minister departs from the auditorium, we would like to invite the Minister to take a group photo with all participants. Could all participants move toward the center? All right. Looking at the camera. And 3, 2, 1. Okay, once again, with your best smile. 3, 2, 1. Okay, thank you. Please accompany the Minister's departure with a warm round of applause. For our media partners, the Minister of Health, Dr. Sanderson Oni, Professor Asnawi Abdullah, and Professor Byron J. Good will now have an official press conference that is now taking place at the lobby, conducted by the Bureau of Communication and Public Services, Ministry of Health. Distinguished guests, please remain seated at the Limena Auditorium. Our knowledge program and detailed chapter by chapter breakdown will proceed shortly. Distinguished guests, please remain seated in the Limena Auditorium. Our knowledge program and detailed chapter by chapter breakdown will proceed shortly. Okay. Distinguished guests, welcome back to the main core of our gathering. We now transition into the substantive core analysis of the Commission report. We invite co-chair Professor Hasbullah to the podium. For a detailed presentation of each chapter of the Lancet Commission, which will be immediately followed by an interactive question and answer session. This information is also available on the page in front of you or on your seats, or you can scan QR at the LED screen, including contacts of the Commissioner for further collaboration or questions. After today's event, Professor Hasbullah, the floor is yours.
Thank you very much. I'm not sure whether I speak in English or bahasa Indonesia. Bahasa. How many of you who need English? No, okay. Thank you very much, everyone who are here in the room or kok jadi bahasa Inggris lagi? Or in the Zoom everywhere. So I'm sorry I speak bahasa Indonesia, yeah, because our audience mostly Indonesian. Terima kasih. Hari ini kita sudah mendapat booster untuk bisa menulis khususnya buat teman-teman yang akan menjadi leader dalam penulisan ini, dan juga teman-teman yang belum menjadi leader bisa berkontribusi. Saya diminta untuk menjelaskan rencana yang akan kita tulis dalam waktu yang singkat sebagai pengenalan dan juga sebagai peta di mana teman-teman nanti bisa berkontribusi, mensinkronisasi apa yang disampaikan oleh Pak Menteri Kesehatan tadi, Pak Budi, untuk betul-betul bisa bersama-sama kita review, kita lihat yang sebaik-baiknya supaya 2045 jangan sampai meleset. Itu aja sebetulnya. Dengan bekerja bersama insya Allah kita akan dapat lebih baik. Next slide. Ya. Nah ini saya sampaikan sedikit saja. 10 tahun yang lalu saya ada Prof. Rina di mana tadi, ya itu ada Prof. Rina, ada Pak Teguh juga udah meninggal sebentar, meninggalkan kita, nanti balik lagi. Sudah mulai nulis, tapi pada waktu itu sebelumnya ketemu Pak Richard Horton, Chief Editor Global, datang ke Indonesia, cerita, ngobrol segala macam, apa yang terjadi di Indonesia dalam bidang healthcare. Kemudian dia bilang, oh, you are doing a lot of things, but we never heard about that. So that's mulainya. Langsung seminggu kemudian dia pulang, dia tulis di editorial dan minta supaya kita menulis review itu. Alhamdulillah bersama FKUI, Prof. Rina jadi lead authornya pada waktu itu. Ini tidak terasa 10 tahun. A lot of things dalam 10 tahun ini sudah kita kerjakan, kita dapatkan, ada transformasi baru. Kalau tidak kita expose juga, jangan-jangan nanti orang nggak tahu lagi. Dan buat saya pribadi, ini bagian yang memang menjadi tantangan. Kita di Indonesia, kira-kira 15-20 tahun yang lalu, saya melakukan kajian singkat berapa publikasi orang Indonesia per 1 juta penduduk. Dan saya bandingkan publikasi orang Malaysia per 1 juta penduduk, publikasi internasional. Publikasi Malaysia 100 kali lebih banyak dari Indonesia. Wah, tapi alhamdulillah sekarang sudah BRIN sudah mengharuskan ada publikasi untuk tiap pegawainya, perguruan tinggi sudah memberikan banyak, alhamdulillah sudah naik. Tapi kalau tidak tulis, nanti apa yang kita sudah rencanakan bisa jadi juga kurang terpantau, ya, kurang mendapat dukungan lebih besar lagi, kurang mengundang generasi muda untuk menulis. Ya, padahal kalau saya baca di dalam Al-Quran 5 ayat pertama yang tulis, itu adalah fondasi untuk bisa majunya suatu ilmu pengetahuan. Baca, tulis, dan knowledge development. Itu 3 bagian yang penting. Nah, ini akan saya sampaikan sedikit perspektifnya yang secara garis besar. Nanti tolong dilihat mana yang bisa teman-teman bisa kontribusi melalui tim yang sudah kita seleksi sebagai tim leadernya. Tapi masih ada 3 chapter kelompok yang belum ketemu. Mungkin nanti ada yang akan melamar lagi. Sebagian ini kita wawancarain untuk bisa memastikan yang melit itu bisa betul-betul menghasilkan publikasi yang singkat, ringkas, tapi juga mempunyai kualitas yang memenuhi syarat dari Lancet. Next slide. Nah, ini adalah chapter 1, kita akan mereview Indonesian Health System Today dulu sebagai baseline. Karena kita untuk sampai 2045 jangan sampai nanti ada middle income trap. Untuk bisa mencapai kemajuan suatu bangsa, kesehatan menjadi syarat utama karena fundamental right-nya di situ, ya. Nah, kita akan melihat benchmarking dulu dengan negara-negara lain untuk mengetahui sampai di mana kita. Dalam tadi yang sudah banyak Pak Menteri sampaikan, kalau kita cuma berjalan sendiri, seringkali kita merasa sudah maju, tapi kita lupa bahwa tetangga kita lebih cepat majunya. Itu bagian yang kita ingin potret di awal sini, ya. Kita akan mencari policy relevan yang sudah di setting visinya tadi oleh Pak Menteri sudah disampaikan, bagaimana kita bisa dapat policy ke depan yang sesuai dengan itu, dan constraint apa yang mungkin terjadi, ini kita akan gali bersama. Jadi bukan satu penulis, ya, yang penting dipahami. Yang ada di meja Anda itu adalah cuman leadernya saja untuk nulis. Nanti teman-teman semua akan gali semua, dan kita akan nulis bagaimana terjadinya koheren antara nasional subnasional. Kita sudah mengambil kebijakan besar desentralisasi. Healthcare, apalagi primary care, itu leadingnya di pemerintah daerah. Ya. Nah, bagaimana kita akan tulis ini? Setelah ini nanti tim akan membahas lebih detail tentang isi-isinya, ya. Tapi kita punya waktu berapa lama ini untuk bisa menulis? Bisa jadi setahun, bisa jadi 2 tahun. Dulu waktu kita 10 tahun yang lalu sama Prof. Rina hampir 2 tahun, ya. Baru 2 tahun lebih, ya, hampir 3 tahun, ya, baru tuntas selesai. Karena kita mesti memastikan datanya valid, perspektifnya benar, semuanya itu supaya koheren. Next slide. Nah, chapter kedua, ya, chapter kedua ini bagian yang paling penting. Equity atau keadilan sosial ini merupakan prinsip dasar dalam Pancasila, kita sudah siapkan itu. Harus semua tercapai. Saya kira ini semua sudah sangat familiar, equity dengan equality. Yang tidak mampu kita harus dukung supaya biar bisa mampu mengakses quality of care dan menjadi orang yang produktif untuk bisa mewujudkan JNI per kapita bisa mengejar Cina sekarang, ya. Tadi Pak Menteri sampaikan Cina sekarang udah $15.000. Kita kalau ekonominya tumbuh dengan 6%, 7%, insya Allah bisa. Tapi target pemerintah sekarang 8%. itu akan lebih tinggi. Nah ini adalah bagian yang harus kita capai untuk mencapai universal akses terhadap layanan kesehatan yang berkualitas dan secara efisien. Ya. Apa yang kita akan ambil sebagai evidence ya, untuk melihat kali ini sampai di mana kita equitable. Belum ada equity. Karena apa? Supply side-nya masih terlalu jauh. Tadi sudah disampaikan juga rencana untuk dan target-targetnya untuk memperbaiki akses. Karena kalau healthcare-nya yang di cover JKN, walaupun sudah bayar iuran, saya setuju dengan Pak Menteri tadi bilang, universal health coverage itu bukan sudah terdaftar di JKN. Ya. Sekarang kalau terdaftar di JKN 99%, tapi lihat duitnya peran JKN baru 30%, something wrong there. Ya. Dan indeks coverage kita, UHC indeks kita pada yang terakhir, evaluasi WHO yang terakhir, itu baru skornya 67, kalah sama Vietnam yang sudah 71. Target di atas 80. Thailand, Malaysia, Cina sudah lewat. Ini bagian yang menjadi penting untuk mencapai equity dalam kondisi kultural kita yang begitu diverse, Bhinneka Tunggal Ika. Dan bagaimana kita bisa melakukan reform supaya betul-betul setiap orang nanti di 2045 bisa mencakup pelayanan kesehatan yang sesuai dengan kebutuhan medisnya. Ya. Nah ini yang kita akan tulis. Nah teman-teman bisa lihat beberapa pertanyaan-pertanyaan key question yang akan kita cari jawabannya. Kalau ada pemikiran mungkin dari tim penulis belum terpikir atau belum ada data, kontribusi dari teman-teman sekalian, itu diharapkan bisa menjadi suara kita di dunia nanti. Next slide. Chapter 3, ini bagian yang sudah jadi target bertahun-tahun. Kalau nggak salah di Alma Ata tahun 1973 juga kita sudah target health for all, dan pada waktu itu karena kita di Indonesia sudah membangun puskesmas sebagai sebuah model untuk health for all, tapi sudah 50 tahun belum tercapai. Bisakah kita lakukan akselerasi? Tadi sama Mbak Enang bilang kita akan targetkan JKN 20% minimal untuk primary care. Alhamdulillah bisa lebih banyak lagi, lebih bagus. Tapi juga financing cuma bagian saja dari pencapaian primary care. Inilah mesin yang bisa meyakinkan bahwa setiap orang bisa dapat pelayanan kesehatan. Kalau primary care-nya bagus, insya Allah kita bisa kejar dengan bagus. Nah, apa evidence-nya yang kita sekarang sudah dapat, apa yang belum tercapai, bagaimana posisi kita di negara-negara setara dengan kita, ini yang akan kita tulis pertama kali. Kemudian bagaimana puskesmas ini bisa digerakkan untuk mencapai posisi pelayanan kualitas yang betul-betul bisa diterima dan bisa diakses oleh semua orang. Baru kemudian jika diperlukan ada referral, kita sudah menggunakan sistem referral. Ini bagian yang banyak negara lain belum sanggup untuk bisa membuat sistem seperti di kita. Tapi bisa jadi tantangan-tantangan ke depan bisa merombak. Nah, bagaimana kita harus mendesain sistem, karena sistem primary care gatekeeper itu adalah efisiensi yang paling tinggi, tapi juga masyarakat punya tuntutan yang lain. Balancing ini yang jadi bagian berat buat kita. Bagaimana mengelolanya, bagaimana pendanaannya, baik di pusat dan di daerah. Nanti teman-teman Bu Balkis, Pak Ahmad itu akan menuliskannya, mendapat masukan dari teman-teman sekalian. Dan bagaimana private primary care juga bisa berperan. Ya, sekarang ini kalau dalam JKN kita lihat 70% dari pasien peserta JKN terdaftarnya di puskesmas. Banyak program-program puskesmas sekarang dengan screening yang sudah bagus, tapi belum bisa semua menikmatinya. Banyak yang terdaftar di private sector, di private FKTP, belum bisa mendapatkan screening yang sama. Bagaimana kita memperkuat private sektornya, itu bagian yang menjadi tantangan besar. Nah, teman-teman yang punya pengalaman, punya visi, punya data, nanti bisa share kepada tim lead yang sudah ada di meja situ, ada emailnya. Next slide. Chapter 4, tentu kalau primary care saja tidak cukup. Sekarang memang kalau lihat data JKN, 87% duit JKN masih larinya ke secondary tertiary care, cuma 13%, tapi kita mau balik, alhamdulillah ini sudah tekad bagus. Nah, tapi kualitasnya mungkin masih belum. Ya, kita tahu patient oriented kita mungkin masih kurang di dalam pelayanan secondary tertiary care ini. Sehingga banyak kita diskusikan orang Indonesia berobat ke luar negeri, kayaknya sih bukan primary care ya kan. Ke luar negeri, pasti secondary tertiary care. Kenapa? Banyak masyarakat kita belum percaya betul kualitas di dalam negeri. Jadi walaupun di sini lebih murah, ada duitnya dia masih keluar. Ini tantangan besar buat kita. Bagaimana kita bisa menyediakan high quality of care yang dipercaya dan juga accessible buat semua orang. Nah, private sector, private financing bagus sebagai komplement buat public financing, tapi kalau terlalu dominasi private financing kayak di Amerika tadi Pak Menteri sampaikan, justru menjadi hambatan. Nah, bagaimana kita mencari evidence, mencari cara-cara ke depan, most cost effective model supaya tetap kita pelihara akses untuk comprehensive healthcare, medically necessary kepada semua orang di 2045. Itu tantangan kita. Ya. Referral behavior sudah kita paksakan dengan sistem JKN, tapi kalau yang non JKN masih sepertiga penduduk kita belum menggunakan JKN walaupun sudah bayar iuran. Ya. Nah, bagaimana mereka bisa menerima referral system supaya efisiensi. Referral system ini efisiensi, bukan membatasi kemauan masyarakat. Behavior masyarakat dan juga behavior tenaga medis, para medis, ini bagian tantangan besar buat kita di sini. Ya. Tentu saja distribusi, ini spesialis kita banyak, tapi banyak yang tidak tersedia di daerah-daerah. Apa insentifnya? Bagaimana sistem bisa memastikan supaya para spesialis yang lagi mau diperbanyak untuk memenuhi kebutuhan di daerah bisa tersedia di samping alatnya. Kalau alat sih gampangan, kita bisa beli dalam waktu 1 tahun bisa kita beli. Tapi mendidik spesialisnya dan mendistribusikannya supaya bisa aksesibel ke daerah. Mungkin juga model sistemnya nanti kita harus bangun bukan model diwajibkan di daerah bekerja sekian tahun. Mungkin ada model baru, model mobile yang bisa lebih memastikan orang mau ke daerah, spesialis mau ke daerah, tidak perlu khawatir anaknya tidak bisa sekolah di sekolah yang bagus atau istrinya, anaknya ke mall yang bagus. Itu bagian yang perlu kita coba pikirkan dalam reform itu untuk bisa memastikan workforce distribution bisa jadi accessible, memastikan equitable di seluruh tanah air. Ya. Nah, tentu saja tantangan lain adalah bagaimana memastikan pelayanan-pelayanan tadi mempunyai kualitas yang setara di daerah. Kalau enggak akan terjadi lagi maldistribusi. Mungkin orangnya sama, fasilitasnya ada, tapi kualitasnya berbeda, akan juga menimbulkan masalah besar. Next slide. Itu chapter keempat. Chapter kelima, Ini bagian chapter yang belum ada leadernya. Nah, kalau ada yang punya fashion, punya interest luar biasa, punya pengalaman, nanti melalui Prof. Asnawi kali sama Sandi, mana Sandi lagi di luar tadi ya, itu dia di belakang. Sampai CV-nya biar kita review. Ini belum ada orangnya nih, Pak Asnawi yang nulis yang tentang hal ini nih. Padahal ini bagian tadi ya, Pak Menteri sudah sampaikan, ini bagian yang harus menjadi salah satu pilarnya di dalam sistem kesehatan kita supaya 2045 betul berkeadilan ya. Ada masalah data, government equity tool-nya ya. Data yang bisa digunakan untuk memastikan kita bisa menggunakan AI ya. Aplikasinya, kemampuan menggunakannya, ini bagian yang terus terang dari tim kami belum ketemu siapa ini yang akan menjadi lead, tapi insya Allah akan ketemu nanti ya. Karena kalau kita tunggu nggak selesai. Telemedicine tentu saja untuk daerah-daerah yang terpencil di ujung-ujung di pulau-pulau kecil nggak bisa ditinggalkan. Ada peluang, alhamdulillah teknologi berkembang, tapi bagaimana kita bisa menggunakannya dengan baik, dengan kualitas yang bagus, pendanaan yang memadai, mudah-mudahan itu bisa mencapai health equity di daerah-daerah yang selama ini belum terjangkau. Mungkin juga ada mobile hospital yang sudah ada beberapa model bisa kita kembangkan, itu bagian-bagian yang menjadi tantangan besar. Jadi kalau teman-teman yang punya keahlian, punya fashion di sini, yuk kita kontribusi supaya Indonesia nggak ketinggalan. Tantangan kita memang agak unik karena pulau-pulaunya sangat tersebar, tetapi kalau di negara lain juga ada yang pulau-pulau di Nordic country juga banyak pulau-pulau bisa terjangkau. Kenapa nggak kita bisa belajar dari sana? Next slide, chapter 5. Chapter 6, nah ini juga bagian yang masih belum kita tentukan siapa yang menjadi leadnya. Kalau ada yang punya fashion, punya kemampuan, punya data, nanti sampaikan ke Pak Sandi atau Pak Asnawi atau ke saya, kita akan bahas ini. Dan nanti setelah ini pun kita akan mencari solusi yang terbaik. Climate change, suka atau tidak suka, akan menjadi masalah besar di dunia. Dan itu masih belum akan terselesaikan, mungkin masih 30-40 tahun lagi. Kita siapkan 2045 sudah visi, sudah ditargetkan. Tapi tantangannya akan jadi compound shock buat kita. Mudah-mudahan ini kita bisa hadapi dengan baik. Perlu orang yang betul-betul bisa melihat dan memformulasikan policy apa nanti untuk bisa kita handle 2045, kita bisa selesaikan itu ya. Nah, tentu saja ada masalah-masalah disaster yang kita negara yang rawan terhadap gempa bumi. Itu baru gempa bumi, mungkin puting beliung tambah banyak ya. Pak Imron ini bagiannya nanti memastikan supaya orang-orang yang punya masalah-masalah beresiko terhadap itu bisa disiapkan. Bagaimana pendanaannya? Karena tidak semuanya juga merupakan bagian dari healthcare system. Governance-nya bagaimana, ini bagian yang menjadi tantangan kita yang harus kita tulis, mudah-mudahan 2 tahun paling lambat atau maksimum 3 tahun bisa kita tulis seperti yang lalu. Chapter yang terakhir adalah kalau semua sudah kita, next slide, kalau semua kita sudah identifikasi kondisi kita sekarang, gap-nya, possible solution, approach, metodologi yang terbaik. Next slide, chapter 7 adalah financing and equitable universal health coverage. Mudah-mudahan skor UHC kita 5 tahun ke depan sudah mencapai 80%. Ini mestinya sudah bisa ya. Kalau Thailand sudah sampai, mestinya kita bisa kalau 5 tahun lagi. Thailand sudah sampai sekarang ya. Bagaimana financing architecture tadi Pak Menteri sampaikan antara public insurance, JKN, private insurance yang komplementer dalam undang-undang SJSN kita sudah siapkan, tapi harus bekerja sinergis supaya mempunyai power bisa mengontrol healthcare providers, mengontrol pendanaan, mengontrol harga-harga obat, reagents dan sebagainya. Kelemahan Amerika yang multi provider, multi insurance gagal mengontrol itu. Tapi di literatur health economics sudah biasa, sudah mengetahui itu, cuman Amerika sudah terlanjur susah sekali berubah. Nah kita mumpung belum punya masalah besar yang masih bisa kita kendalikan, mudah-mudahan financing arsitekturnya kita bisa sepakati bersama sehingga kita bisa mencapai efisiensi. Yang tadi Pak Menteri bilang kalau appendektomi di Amerika $12.000, di Jepang kenapa bisa $5.000? Karena di Jepang ada financing arsitektur yang disepakati bersama, apapun sumber dananya harganya sekian. Kontrol, power control dari pemerintah, government itu menjadi penting. Kita terlalu kencang kontrolnya kali sekarang ya, tapi nanti nggak akan berkembang juga. Nah, balance ini jadi penting. Dan dari mana uangnya nanti akan dimobilisir, bagaimana perhitungannya? Alhamdulillah ini nanti Pak Teguh, mantan dekan di Fakultas Ekonomi dan Bisnis UI bisa mendalami, dan beliau juga sudah ikut pada waktu kita menulis Lancet yang pertama yang terbit 2018 tadi itu ya. Strategic purchasing itu bagian yang masih dalam berbagai perdebatan sekarang. Kita mau coba dengan DRG sistemnya, DRG alatnya, tetapi berapa nilainya yang fair, yang optimum, bisa menyampaikan menghasilkan kualitas yang bagus tapi dengan harga yang terbaik. Itu kuncinya pada strategic purchasing reform. Teman-teman yang punya pengalaman, punya visi, punya data, nanti kita share ya melalui Pak Teguh ya. Adjustment di mana kita harus adjust dari yang sekarang bagus, kita akan pelihara. Mungkin yang underfunded atau underpriced kita angkat sampai di mana itu. Ini seninya dan teknologinya cukup rumit, tapi IT bisa membantu kita ya. Kalau yang kelebihan bagaimana kita kontrol, itu merupakan bagian yang menjadi tantangan kita supaya bisa tercapai UHC yang equitable. Next, terakhir, ini adalah bagian yang nanti kita gotong bersama-sama memastikan data yang akan kita gunakan untuk assessment pada kondisi sekarang dan bagaimana kita akan capai di 2045 harus valid, dan perspektif apa? Tentu perspektif pasien lah, perspektif peserta lah, perspektif penduduk lah yang harus dilihat, bukan hanya perspektif providers atau perspektif pendanaan kesehatan yang sekarang ini masih sering terjadi perdebatan karena melihatnya dari perspektif yang berbeda-beda. Saya kira ini yang akan kita bahas secara garis besar. Lancet menyediakan 25,000 words or more. Yeah, okay. It is difficult to compress but complete, and hopefully also evidence-based and achievable. Nah, saya kira itu yang akan kita sampaikan, kita tulis. Semua ini adalah bagian dari semua kita, cuma sebagian yang doyan nulis saja, nanti yang menuliskan. Kontribusi dari teman-teman semua merupakan kerja tim. Kita sudah rekrut dari berbagai perguruan tinggi supaya bisa mewakili semua. Teman-teman dari Kemkes, dari daerah yang punya pengalaman, punya data, itu bisa berkontribusi. ada pembagian tugas. Kalau Pak Menteri bilang saya mau nulis buku nggak bisa, ya memang kalau eksekutif tugasnya yang ngomong ngelit, jangan mau nulis lagi nanti kagak beres-beres ya. Nah kita ini yang punya waktu untuk menulis dan punya fashion untuk menulis, dia menuliskannya supaya bisa dibaca oleh orang lain menjadi penggerak untuk mencapai kemajuan 2045 yang kita cita-citakan. Terima kasih. Kalau ada pertanyaan, ada waktu Q&A kan?
Yes.
Oke.
Ya.
Tapi nanti yang jawab jangan saya sendirian ya, ada teman-teman saya nih yang pada nulis ini. Silakan, siapa? Yes, satu.
Baik Bapak Ibu
Nanti.
dipersilakan untuk dapat
Kalau
menyampaikan
tidak mau
pertanyaan.
bertanya juga menghujat juga boleh, ya. Kontribusi boleh. Yang penting kita bangun ini supaya jadi publikasi Indonesia. Ya silakan.
Baik, terima kasih Prof. Perkenalkan saya Siti Badriah, Direktur Poltekkes Kemenkes Jakarta 3. Baik, pada kesempatan ini kami dari Poltekkes sangat mengapresiasi kegiatan ini Prof. Apalagi tadi yang disampaikan oleh Prof, tujuannya kita tahu arahnya kemana. Dan saya melihat ini bukan hanya suatu wadah untuk selain publikasi kelas dunia, tetapi lebih dari itu. Tadi seperti yang disampaikan oleh Pak Menteri, kita berharap dari sini itu bisa mencapai Indonesia Emas 2045. Izin Prof, saya ingin menyampaikan bahwa kegiatan ini mungkin kami ingin menyampaikan dulu Poltekkes di bawah Kementerian Kesehatan.
Ada berapa sekarang Poltekkes?
Ada 38 Prof.
38.
Ada 38 Poltekkes dan tersebar di seluruh Indonesia, bukan hanya di perkotaan tapi juga ada kelas-kelas jauh yang ada di daerah terpencil, daerah terjauh dan lain sebagainya. Nah, kami memiliki sumber daya manusia bukan hanya peneliti dari dosen tetapi juga mahasiswa. Dan dari sana kami ingin bertanya barangkali Prof. Yang pertama, apakah di sini apakah nanti akan ada rancangan yang disusun secara sistematis bagaimana dari seluruh lini, mungkin bukan hanya Poltekkes, termasuk PTN di luar, ada dosen dan terutama adalah mahasiswa, karena kalau dilihat tujuan kita adalah 2045 adalah untuk mencapai Indonesia Emas. Nah, apakah orang-orang muda sekarang termasuk mahasiswa yang nantinya mungkin di 2045 akan menjadi pelaku bahkan mungkin pemimpin dari sistem kesehatan itu bisa masuk ke dalam sistem ini? Karena saya melihat ini adalah ekosistem yang bagus, bagaimana policy atau kebijakan didasarkan pada evidence base, dan kita sudah terbiasa dengan riset, pengambilan data, dan pada akhirnya mungkin kami juga siap jika nanti dilibatkan dalam implementasi kebijakan yang dibangun. Demikian Prof, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Alhamdulillah, itu bagian yang menjadi dream kita. Yang generasi muda, yang mahasiswa sekarang, mudah-mudahan terinspirasi dari tulisan ini, kemudian bertekad, saya mau nulis lebih banyak. Walaupun kita akan nulis mungkin satu commission namanya, sedikit nulisannya. Tapi insya Allah nanti teman-teman para komisioner ini, kita sebutnya komisioner yang akan nulis ini ya. Bukan komisioner di perusahaan PT yang duitnya gedean dikit itu, kalau itu bukan ya. Tapi komisioner menulis ini ya. Nanti Pak Sandi mungkin bisa tambah bantu itu. Welcome segala macam input. Kalau ada pentolan-pentolan di Poltekkes maupun daerah terpencil, tapi jangan salah paham. Orang yang daerah terpencil mungkin bisa melihat lebih objektif daripada kita yang di kota-kota. Udah teracunin sama yang tiap hari terekspos, kemudian ya kurang dalam. Silahkan ya kontribusi. Nanti mungkin Pak Sandi, Pak Asmawi, kita bisa akomodir bagaimana mekanismenya ya supaya bisa mungkin Mas Sandi mau tambah penjelasan, silakan. Oh, itunya. Ini nih. Ada. Oke.
Ya. Teman-teman, terima kasih Bu untuk pertanyaannya. Ini nggak apa-apa kan saya duduk sebelah Ibu.
Paling tidak itu sudah mulai ada pendekatan.
Iya.
Dekat-dekat.
Kita bikin kertas ini bukan cuman ada chapter-chapternya. So we made this not only to outline the chapters that we're beginning with, tetapi juga ada kontak untuk beberapa chapter. There are also the emails and the contacts of some of the chapters. And so we don't know exactly how this is going to work. Kami belum sempurna karena kita Indonesia belum menjalankan komisi.
Yeah.
Sebelumnya, we haven't done a commission like this before. So this is something that we're open to discussing together. Ini satu hal yang kita sangat terbuka, kita diskusi sama-sama. Terima kasih sama BKPK, terima kasih Prof. Asnawi sudah menyediakan kopi di depan. Jadi kita sambil ngobrol,
okay.
nanti, tapi kita sambil ngobrol, we can chat. This is where we think about what we're doing together. Ya, seperti itu, Bu. Thank you.
Oke, ada dari komisioner lain mau tambahin? Kalau enggak, we take another question. Ya, silakan.
Baik, terima kasih Prof.
Ya.
Perkenalkan saya Vivi Setiawati dari Rumah Sakit Sulianti Saroso. Terima kasih untuk paparannya Prof, tadi sangat menarik. Kami di rumah sakit ada Clinical Research Unit yang mendapat tugas dari Bapak Menteri untuk melakukan penelitian-penelitian kesehatan yang implementasi langsung kepada diagnosis. Nah, salah satunya yang tadi menarik adalah tentang teknologi.
Yeah.
Nah, di rumah sakit kami ada penugasan dari Bapak Menteri Kesehatan, yaitu ada Biomedical Science Based Initiative. Jadi kita ada penelitian-penelitian terkait biomedik. Dan ini sangat hal yang baru sekali, di mana nanti hasilnya akan langsung diimplementasikan kepada pasien. Kalau memang ada yang perlu langsung diagnosis base untuk terapi pada pasien. Nah, ini teknologi ini baru, Prof. Jadi kalau memang nanti kita bisa untuk mengembangkan, bisa memasukkan juga di dalam tulisan ini atau artikel ini, kami siap ada sekitar 10 rumah sakit yang memang mengembangkan BGSI, singkatannya Prof, BGSI. Ini terkait dengan penyakit infeksi, kanker, dan juga penyakit-penyakit non-communicable. Dan communicable disease. Jadi nanti kami sangat berterima kasih kalau memang ada dari kami di rumah sakit yang bisa ikut terlibat dalam pengembangan teknologi untuk penulisan dalam kegiatan ini. Terima kasih Prof.
Alhamdulillah. Ya, ini bagian Mas Andi atau Prof. Asnawi mesti dicatat nih, karena memang kita yang digital teknologi belum ada identifikasi orangnya. Ya. WA nanti ya atau kirim itu ya biar kita lanjutkan. Oke. Ini usulan. Any more?
Panji depan, Panji.
Atau tadi Pak Sandi udah manggil. Itu satu di belakang lagi di belakang. Ya, silakan. Mohon mic-nya. Di belakang dulu. Belakang dulu. Habis ini baru di depan KSP ya. Ya.
Selamat Prof, pertama-tama atas launching commissionnya dan Bapak Ibu sekalian para komisioner. Saya Suci dari BPJS Kesehatan. Izin bertanya Prof, kira-kira kolaborasinya itu nanti kalau dengan BPJS Kesehatan itu seperti apa Prof? Terima kasih.
Ini yang paling tahu Mas Handi yang jawab ini. Ya.
Terima kasih Mbak. Jadi memang dengan stakeholder ada 3 fokusnya. 1, untuk kita kolaborasi adalah kita analisis data sama-sama. Karena banyak sekali datanya, sampai kadang-kadang mikir ini analisisnya mulainya dari mana gitu. We have so much data that sometimes we don't know where to start analyzing from. So that's the first thing. Number 2 is that sepanjang komisi ini kita tentunya mau dengar banyak suara tentunya dari BPJS Kesehatan, dari rumah sakit, dari berbagai tempat. Kita pasti akan ada meeting, konsultasi, dan workshop. To capture all the voices, we're going to have workshops, consultations, and meetings to make sure that whatever we produce not only supports the ministries, but supports the people and their voices as well. Jadi kita untuk bisa representasikan berbagai stakeholders. Ketiga, dan ini yang saya sangat-sangat excited, yuk kita menulis dan publikasi sama-sama. Supaya kita lebih terrepresentasi di literatur. Memang karena datanya, kadang-kadang datanya ada, analisisnya ada, tapi untuk diubah menjadi satu paper yang publishable di jurnal internasional, sepaneng. Cara penulisannya, formattingnya, let's work together to do that. to be able to write and publish together. Seperti itu sih, Pak. Terima kasih.
Juga saya tambahan lagi, yang kita tulis ini bukan satu-satunya. Jadi kalau nanti ada input data BPJS luar biasa kaya itu, ya bisa ditulis banyak, bisa ditulis paper-paper independence, bukan yang sini, tetapi kita bisa saling mengisi untuk memperbaiki akseptabilitas ya dari data itu. Itu bagian yang kita ingin spill over-nya itu makin banyak, makin bagus. Supaya jangan ketinggalan sama teman yang Malaysia aja dulu yang disebutin yang satu rumpun tapi publikasinya lebih banyak. Kita budaya ngerumpinya diganti supaya budaya menulis. Nah, itu penting. Mbak, silakan.
Terima kasih Prof. Mohon perkenalkan, saya Dr. Adele Hutapea mewakili PLT Deputi 3 dari kedeputian di kantor staf Presiden. Pada hari yang berbahagia ini, kami sangat mengapresiasi dan menyampaikan penghargaan yang setinggi-tingginya kepada Kementerian Kesehatan dan seluruh instrumen kebijakan kesehatan nasional dan menyampaikan harapan yang tinggi untuk hasil terbaik yang bisa kita miliki. Hasil penulisan 7 chapters yang tadi Profesor sudah sampaikan, bahwa di dalam tahun 2025 sampai dengan 2029 kita secara nasional sedang dan akan memiliki beberapa program Astacita prioritas Presiden terkait dengan percepatan pemastian akses pelayanan kesehatan bermutu bagi seluruh rakyat Indonesia. Antara lain kita akan memasuki gerbang besar kita, eliminasi tuberkulosis sampai dengan tahun 2029 sebagai target kita untuk mengakhiri tuberkulosis di Indonesia tahun 2030. Dengan demikian kita juga akan memiliki 66 rumah sakit umum daerah tipe C yang saat ini masih selesai di angka 22 unit, tetapi kita masih tetap berjuang untuk memastikan bahwa rumah sakit itu berfungsi sesuai tujuannya. Lalu ada cek kesehatan gratis atau pemeriksaan kesehatan gratis untuk menjangkau 80% penduduk Indonesia multi-year di dalam tahun 2025 sampai dengan 2029. Dan kita masih memiliki PR tentang stunting, lalu revitalisasi pelayanan kesehatan primer melalui puskesmas dan puskesmas pembantu, laboratorium daerah. Overall, seluruhnya itu adalah tantangan yang akan bermanfaat dan bermakna untuk remarkable di dalam penulisan hasil kerja keras komisi kita ini nanti. Dan oleh sebab itu kantor staf Presiden membuka pintu seluas yang kami dapat berikan untuk mendukung keberhasilan penulisan seluruh yang kita bicarakan pagi ini agar menjadi kenyataan tepat waktu. Demikian kami yang bisa sampaikan, Prof. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Nah ini Pak Sandi, teman-teman Komisi E, sudah ada tawaran luar biasa. Data cek kesehatan gratis jangan cuma dilihat dari cek kesehatan gratisnya, tapi ini adalah data dasar. Kita bisa tahu berapa banyak yang nanti bakal sakit dan menikmatin, sorry to say, karena berobat itu hanya penikmatan juga. Menikmatin berobat untuk jangka panjang. Kalau kita sudah punya data tadi, kita petakan, analisis bersama, ini menjadi evidence. Bagaimana kita bisa membuat perencanaan yang bagus 2045. Kalau sekarang mungkin baru 1/4 dari yang diabetes yang terkontrol, rajin berobat, 2045 itu ya kalau bisa 100%. Tapi kalau nggak ada data hasil screening, hasil cek kesehatan gratis, kita nggak tahu berapa. Nah ini teman-teman nanti kita bisa analisis ya sebagai dasar udah dibuka dari KSP. Saya kayaknya udah mau ditegur nih. Ya, terima kasih banyak supaya sebelum diturunkan saya akan turun sendiri mudah-mudahan. Terima kasih atas perhatiannya. Ini baru awal, insya Allah kita bisa bersama, kita bisa capai yang kita siapkan bersama. Makasih banyak Mbak. Makasih. Assalamualaikum warahmatullahi wabarakatuh. Lebih kurangnya mohon maaf.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor Hasbullah, for the comprehensive presentation, and to all participants for the engaging and deeply enlightening discussion. Excellencies, distinguished guests, this successfully concludes the Lancet Regional Health Western Pacific Commission launch, Reimagining Healthcare in Indonesia for 2045. On behalf of the organizing committee, the Ministry of Health of the Republic of Indonesia, Budi Gunadi Sadikin, Vice Minister of Health of the Republic of Indonesia, Benjamin Paulus Octavianus, and the Lancet Regional Health Western Pacific Commission, we would like to express our deepest gratitude. Thank you for your presence, your invaluable insights, and your unwavering commitment to building a healthier tomorrow. We cordially invite all distinguished guests to proceed to the foyer to enjoy the morning break refreshments and to continue having networking with the commissioners, development partners, and research colleagues. We wish you all continued success and a very safe journey back to your destinations. Have a pleasant day ahead, and thank you.
What's your story? What's your sign? It's like we're twin flames in a different life. Deep connection lights a spark. It's like you know me in the depths of my